Good afternoon, everybody. I would like to thank Madam for giving me the opportunity to speak today. So, moving on to the recent advances in gynecological cancers pertaining to medical oncology, much of it has been discussed yesterday, and as you know, the most recent advances have happened in the field of PARP inhibitors in the first line. So, I would be actually covering Solo 1 7-year follow-up data. Athena mono, the combo results are not out. The role of rucaparib maintenance in first line. Then mirvetuximab approval in platinum-resistant ovarian cancer. The role of trametinib, there is an exciting data there in the low-grade serous ovarian carcinoma, and also the CALA trial, which was negative in cervical cancer. So moving on, this was the TMH meta-analysis, maintenance therapy with a PARP inhibitor in patients with newly diagnosed advanced epithelial ovarian cancer. It was an individual patient data and also a trial level meta-analysis, and the extracted individual data actually showed that the individual patient PFS, the median PFS was significantly longer in the PARP inhibitor versus placebo groups. As we can see, there was the response varied in different subgroups, and the most important subgroup to benefit was patients with germline and tumor BRCA mutation, wherein there was a benefit of 45 months versus 17 months, and also in the HRD positive status, including BRCA mutation, that is 34.7 months versus 17.9 months. As we move down, when we go to the HRD negative subgroup, we can clearly see that the benefit was very minimal, 15 months versus 11.3 months. So moving on, the approval of olaparib as maintenance in first line. So this was in newly diagnosed ovarian cancers with BRCA mutation, and patients with newly diagnosed FIGO stage 3 and 4, high-grade serous endometrioid, ovarian, fallopian tube, or primary peritoneal cancers with BRCA mutation were randomized to receive olaparib 300 BD versus placebo. The earlier trial, as we have seen, that showed a benefit, a huge PFS benefit of 56 months, and that's why the 7-year follow-up was done to assess long-term efficacy and the tolerance to 2 years of olaparib. So when we go to the baseline characteristics, they were well matched. As we can see, the most important to highlight is this trial studied the BRCA mutated cohort, that the germline or the tumor BRCA, and around 80% of them had undergone a good interval cytoreductive surgery, and most of them had developed a clinical response. So as we can see that the follow-up data had clearly shown that the median OS was not reached in the olaparib versus the placebo. And also we saw that the PFS1 and PFS2, that is the time from random assignment to the first subsequent therapy or death, there was a benefit in that, 64 months versus 15 months in placebo, versus the time from random assignment to second subsequent therapy also, PFS2 also, there was a benefit of 93 months versus the 40 months in placebo. So when we give something in first line, we have to be very careful and watchful for the side effects and also the safety. So adverse events leading to dose reductions were there in about 30% of patients, and the adverse event of special interest, that is the MDS and AML, was only 3%. What is important to know that the adverse event leading to treatment discontinuation was there in a very small subgroup of patients. So these were the common side effects when we give olaparib in first line: nausea, fatigue, vomiting, anemia, diarrhea, arthralgia, and constipation. So moving on, after the approval of olaparib in first line, then came the Athena mono, that was the approval of the maintenance rucaparib. After one-line treatment with platinum-based chemo in advanced ovarian cancer, the combo results are not out. Basically the adults with newly diagnosed advanced high-grade epithelial ovarian or primary peritoneal cancers who have completed cytoreductive surgery, who received around 4 to 8 cycles of first-line chemo, they were randomized to receive rucaparib versus the placebo. So the primary endpoint was investigator-assessed PFS, and that actually showed that the investigator-assessed PFS rucaparib maintenance significantly prolonged the investigator-assessed PFS versus placebo in the HRD population. So this trial actually showed the benefit of rucaparib in quite a broader subset of population. So I will go back. I wanted to highlight the baseline characteristics, and as we can see, this trial had quite a significant number of patients with BRCA wild type and also with low loss of heterozygosity, or it also had the HRD negative population, apart from also having the BRCA mutated population. So we saw that rucaparib maintenance significantly prolonged investigator assessed PFS versus placebo in HRD population, and these results were also confirmed with a blinded independent review. Apart from that, the rucaparib maintenance significantly prolonged the investigator-assessed PFS versus placebo, even in the intent to treat population, that is 20 versus 9.2 months. So, but we also learned that the investigator-assessed PFS benefit observed with rucaparib was independent of BRCA and HRD status. What is most important is the quantum and the magnitude of benefit might be very less in the HRD negative population. Also, the trial claims it's to the tune of only about 3 months in the HRD negative population. So when we go to the safety and tolerability, so the treatment interruptions happened in around 60% of patients who received rucaparib, and dose reductions were there in 49% of patients. So when we give the other special concern was the increased ALT and AST, which occurred in around 42% of patients, which required some dose reduction. So the most common grade 3 to 4 side effects were grade 3 to 4 asthenia, fatigue, anemia, neutropenia, thrombocytopenia, abdominal pain, and diarrhea. These are the common concerns when you prescribe rucaparib in clinics. So when we go to the disease risk subgroups from Athena mono study design, we also see that even when you calculate the PFS by surgical outcome, we also saw that there was no difference in treatment effect across the subgroups, whether the patient had a R0 resection or a non-R0 resection. So moving on from the PARP inhibitors point of view, the next development which happened was the SORAYA trial. That was the role of mirvetuximab soravtansine in platinum-resistant ovarian cancer. And this was a study which was actually biomarker-driven. That is, it was a global single-arm phase 3 study of mirvetuximab, folate receptor alpha targeting antibody drug conjugate with a potent DM4 delivered to the tumor cells. Earlier on, it had showed some activity in patients with FR alpha high platinum resistant ovarian cancer with an overall response rates of about 32%. So patients with platinum resistant cancer who have received 1 or 3 prior regimens, they have received bevacizumab, they have also received bevacizumab, and they could receive PARP inhibitors. They were actually randomized to receive mirvetuximab 6 mg per kg 3 weekly and continued until PD, unacceptable toxicity and progression. 80% had unknown BRCA mutation status, and 100% had received prior bevacizumab, and 48% had received previous PARP inhibitor. So as we can see, there was a clinically meaningful activity seen in patients with FR alpha high platinum resistant ovarian cancer. Important to highlight that 5 patients actually had a complete response. The overall response rate, if a patient had received 1 to 2 lines of therapy, was 35%, and the overall response rate, if the patient received 3 lines of therapy, was still 30%. So overall, the median duration of response and by prior PARP inhibitor was comparable between those who were heavily pre-treated, those with 1 or 2 prior lines versus 3 lines of therapy. So moving on, when we give an antibody drug conjugate, the important is to keep a watch over the adverse events of special interest. Most ocular and GI adverse events were low grade and reversible. 8% of patients had grade 3 or more than serious side effects that led to a dose delay, but all the ocular side effects were actually manageable. 1 patient death was reported on study that was deemed possibly related to the study drug respiratory failure. So moving on, the next area of interest was the treatment of recurrent low-grade serous ovarian cancer. And this was an international randomized open-label multi-center phase 2-3 trial. Eligible patients were aged 18 years or older with recurrent low-grade serous carcinoma following initial diagnosis of ovarian or peritoneal low-grade serous carcinoma or serous borderline tumors. Patients were eligible if they had previously received at least 1 platinum-based chemotherapy regimen. So the important thing about this trial is that it was comparing trametinib versus physician's choice, and the physician's choice included chemotherapy, paclitaxel, lipodox, topotecan. It had also included letrozole and tamoxifen in the other arm. So these were the characteristics of patients at baseline. Trametinib is a MEK1 and MEK2 inhibitor, and it was also found based on the mutational status that the KRAS, BRAF or NRAS mutation was found in 17% in both the groups, KRAS in 11%, BRAF in 1%, and NRAS in 5%. So also we saw that the standard of care group, as I had mentioned, included both hormones and also the physician's choice chemotherapy that we would prefer in giving in a platinum resistant setting. So in a low grade this thing. So letrozole, tamoxifen, paclitaxel, lipodox, and topotecan. So it was found that the trametinib had caused a PFS benefit of 13 versus 7.2 months, and also in the pre-specified subgroup in patients who were pre-specified to receive letrozole, around 87 patients, they also had a PFS benefit when they received trametinib oral 2 mg per kg, 15 versus 10.6 months. The forest plot of multivariable adjusted treatment hazard ratio across the levels of each stratification factors all favor the use of trametinib. Also important is to understand the presence or absence of mutation did not make any change in the PFS benefit, and both the groups actually had a benefit in the PFS. So this was the first positive randomized clinical trial of a MEK inhibitor reported in low-grade serous ovarian cancer. The study also shows the use of oral MEK inhibitor trametinib significantly increased progression-free survival and objective response rate compared with the standard of care therapies in patients with relapsed or persistent low-grade serous ovarian cancer. These outcomes were achieved without a clinically significant effect of the therapy on the quality of life. So moving on to the next study, that was the CALA trial. Even though it was a negative trial, it deserved a mention because the expectation was that CTRT and immunotherapy would work together. It looked into the efficacy and safety of concurrent and adjuvant durvalumab with chemoradiotherapy versus chemoradiotherapy alone in women with locally advanced cervical cancer. It was a phase 3 randomized multi-center international double-blind placebo-controlled trial. Immunotherapy naive patients of cervical cancer of all histologies, 1B2 through to stage 4A with any node stage, where 714 patients were randomized 1:1 with durvalumab plus CTRT versus placebo plus concurrent CTRT. And the idea was that the chemoradiation induces tumor cell death, activates 1C and promotes tumor cell phagocytosis, and the PDL-L1 blockade actually can disinhibit or activate the chemoradiation immunogenicity. But it was found that durvalumab given concurrently with chemoradiation was not found to significantly improve progression-free survival versus chemoradiation alone in patients with locally advanced cervical cancer, missing the primary endpoint of the phase 3 CALA trial. Thank you.